If you look here, we have so many newer things that have happened. You look at the multimodal imaging. So this is a picture of an OCT angiography where you can see from the OCT angiography, you can see here a neovascularization. And the beauty is that if you go to the you can actually demonstrate a flow on a B scan, and you know that this is an elevated NVE. You look at the peripapillary area where we have NVD, and there is, you can identify the blood vessels and do a B scan and demonstrate a flow within this within these vessels without your view being obstructed from the normal leakage. We have also learned to look at the retina, which Dr. Manpreet would be talking, in different slabs from the surface to the deep. And we have identified that fluorescent angiography would not be able to tell us picture about the ischemia which is occurring in diabetic macular edema, which actually happens at the deep capillary plexus. You can see here the ischemic zone of capillary non-perfusion. We also have learnt algorithmic approach to managing diabetic retinopathy, and this I will allude at a later point. And we have newer lasers available like the Navilas and the micropulse, and we all know that how beautifully anti-VEGF take care of diabetic macular edema, and Vishal will be covering about the vitrectomy in diabetic macular edema and diabetic PDR cases. So this is a course, practical and protocol-based management of DME, and I have a galaxy of well-known speakers, and we have the keynote address by Dr. Bhaskar Gupta, who is from Southampton. So here I have Dr. Manpreet. Dr. Neeraj Sandoi has not been able to make it due to an emergency. We have Professor Atul Kumar, who will be joining in a short while. Dr. Dinesh is coming. Dr. Vishal Agarwal from SMS, Dr. Ritu, Dr. Bhaskar Gupta, and that's me. Dr. Bhaskar is a consultant, we are a surgeon, and all the galaxy of speakers don't need any introduction. But Bhaskar Gupta is new to for many of you, so I'm introducing him. He is a consultant surgeon from the University Hospital Southampton. He did his post-graduation in India, followed by DM research project under Professor Shobha Shivaprasad at Moorfields, and he has over 50 peer-reviewed publications. So after our session is over, we'll go to an interactive session of about 12 minutes, where we'll be putting up some clinical situations and discussing it openly between all of us, and you are free to answer questions, ask questions. So the definition of diabetic macular edema over the years has changed. We used to define the clinically significant diabetic macular edema. It's become much simpler now. We have a center involving diabetic macular edema, which is in the central subfield, and you have a non-center involving diabetic macular edema. If you have a center involving DME, you treat it with anti-VEGF. If you have a non-center involving DME, you identify the leaking microaneurysm on an angiography and treat it with focal laser by the ETDRS protocol. We have learned more about pathomechanisms. So we know that there's a thickening of the basal membrane, there is apoptosis of pericytes, dropout of pericytes, there are changes in the endothelial cells, and there are changes which are happening which cause stickiness of the endothelial cells, and which leads to exudation and retinal hemorrhages and formation of microaneurysms. And because of the ischemic factor, predominantly VEGF, we have ischemia, and we have capillary non-perfusion area, which eventually leads to formation of neovascularization. We have numerous biochemical markers. I will not go into the details, but the triggering factor is hyperglycemia. This hyperglycemia leads to a cascade of events which occur. There is a PKC activation, there is an advanced glycation end product. So this basically leads to vascular endothelial dysfunction, and that you can have retinal ischemia, so you treat it with laser. Then you give steroids which act to reduce the permeability of the vessels, and we have against VEGF, so we have anti-VEGFs which take care of the increased VEGF, and then we have other factors for which newer drugs have come but not yet being clinically so much used. They are still experimental. So there is a disruption of the blood-retinal barrier. There are certain hematological and rheological changes, and we know clearly now you can see here the capillary non-perfusion, how beautifully a microaneurysm forms. And we have a multitude of these problems which have to be taken care of in a systematic manner. I'll be alluding later on the importance of the artificial intelligence, and we can now screen for diabetic retinopathy without the patient being next to you. You will get the images and you can accordingly advise the patient. And mind you, this will not lose, we are not going to lose our jobs by artificial intelligence, which I'll show you later on. I alluded before this that if you have a central involving diabetic macular edema, we don't go ahead and this is the laser which I had done way back in 2004. You can see how close to the fovea we used to go when we didn't have anti-VEGFs available. These patients used to do well. However, if we have anti-VEGFs with a central involving diabetic macular edema, today we'll be injecting anti-VEGFs, and for the non-central involving, we'll go ahead with lasers. So if you have a central involving diabetic macular edema, if the patient is symptomatic, you treat with anti-VEGF. If the patient is not symptomatic, that means the vision has not come down, and we will discuss this part of the clinical trials. Then we can wait and watch, and always metabolic control should go in all stages of diabetic retinopathy. Metabolic control is very important, whether it is non-proliferative or a proliferative diabetic retinopathy. If you have extra foveal macular edema, you identify the macular aneurysm by the angiography and you treat it with focal laser. If you have a PDR patient, then with a PDR, if you have DME, which you treat with anti-VEGFs and then do laser, and eventually if you have vitreous hemorrhage, which Vishal will be talking about, you do vitrectomy. If you don't have any diabetic macular edema, central involving, you can go ahead directly with PRP. In DME or diabetic retinopathy in a pregnant woman, it's important not to inject anti-VEGFs. So if you have a diabetic macular edema, you could either wait or you could inject steroids. But if you have laserable PDR, go ahead and do the laser. Laser is not a contraindication. So just a little bit about the metabolic control. This patient refused any intervention. This slide actually I have obtained from Dr. Manga Dogra. We have a patient, so this patient was followed very intensively for 6 months, and this is after the very good metabolic control, the right eye and the left eye, the patient did extremely well. There is one other patient who walked into my OPD who had never been to a diabetic. 8 months after dialysis and metabolic control, see how the picture is beautifully changed. So it's very important that Dinesh will be covering this. It's very important that we have a good metabolic control. And just to tell you a little bit that micropulse laser may have, Dinesh, why don't you come and join us here? Micropulse laser is effective without scarring. We can treat diabetic macular edema, which shows that microperimetry is benefited. So the take-home message is good metabolic control, use of anti-VEGFs, focal laser for non-central involving DME, ranibizumab for PDR, and with a diabetic macular edema, and one could defer laser, and of course vitrectomy, which I will be mentioning. And I will just stimulate your thinking process. You have a patient with persistent diabetic macular edema, the cystoid spaces. Patient has received 8 injections of anti-VEGFs, 4 injections of Ozurdex. Ozurdex is not available in the market. What are we going to do? So these are the sort of panel discussion we'll have, and we have some solutions for this. So thank you very much. That is my introduction for my speakers. I would now our first speaker, Dr. Manpreet, is just reaching. I will request Dr. Bhaskar Gupta, who is from, to give his keynote address. And actually, his keynote address, which was mentioned in the AIOS, I had actually requested him to change it to some extent so that we can learn from him how they do it in the UK. Dr. Bhaskar. I think he will just correct it.
Thanks, Ajay, for the invitation. Thanks, organizers. As the slides get loaded, thanks. Right. Okay. I've got no financial interest to disclose here, So we thought when we were talking to, me and Ajay were talking, we thought we will tailor this talk and give some insight of how the diabetes in general is managed in UK. Bear in mind that every state, every country has a different pathways which is dependent on the population, what the state-sponsored sort of services are. And I'm very mindful that it is not replicable or in India because of the resources and everything, but I will give you some insights how we manage, okay? So generally all the people who live in UK, they have a registered doctor, and as soon as a person is diagnosed with diabetes, there is a diabetic registers which goes into it. And this diabetic register feeds into the diabetic screening program, which is called as the NHS diabetic screening program, which gets updated every month, okay? So from there on, next please. Next slide. Okay. So what happens from there, the national screening program, there are different screening programs in different regions of the UK. They send an invitee for that patient to come and have the diabetic screening program. Just to give you a synopsis of things, we have got about 60 million people living in UK, and the current data from 2016-17 Department of Health says there are about 3 million diabetics, so that about 5% of people are diabetic. As expectedly, 90% are type 2 diabetics, and 2.6 million in a year were offered diabetic screening to attend so that they can have their pictures taken, and there were 2.2 million people who actually attended. So it's a well sort of a program running very well, about 85 to 90% sort of an intake as well. So bear in mind that has an important bearing. So what happens when that patient goes to the screening program? Obviously they will have the vision, they will have the dilation, and then they get two field stereopsis pictures taken. One is a disc center and one is the macular centers, okay? So from then that it goes to the grader, who are primary grader. Bear in mind that they are not ophthalmologists, they are technicians who have been trained to grade the images. And I've just put in a slide highlighting how the English screening programs work. We grade into R0, R1, R2, and I've put an equivalent grades of the ETDRS as well. So basically R0 means there's no diabetic retinopathy, they get sent home, or means all these patients get home after the pictures, and they get an annual appointment that is automatically generated. R1 is your equivalent of mild to moderate. Again, they remain in the population, they get a 6 yearly appointment as well. R2, which is your moderate to very severe non-proliferative diabetic retinopathy, they get sent to the hospital eye services. So up till now, the patient is all in the primary care. It's not coming to the secondary care, which is the hospital. And bear in mind, everything is free. There's no costing involved to the patient also. Okay, so they get referred to be seen in the hospital, and we have a target that we need to see these patients within 6 weeks. Okay, and people who are diabetic, means a proliferative disease, they again hospital, and we have a target to see them within the 2 weeks appointment. Okay, similarly, there is a maculopathy as well. With no maculopathy, they remain in the community, get seen every year. Then any maculopathy, they get referred to the hospital secondary eye care. And then this is the criteria of it. So a lot of referrals come to the hospital eye services because of the strict criteria. Okay, bear in mind, again, these are not ophthalmologists. They have to stick to these graders, have to stick to these criteria, and the hospital has a duty to take on these referrals. So we do generate a lot of false referrals from these because they may not be necessarily needing treating. So what has happened, this is what we are trying to replicate across the country in the UK. This is a flow chart from my sort of a Southampton hospital. So when these patients get referral, what we have tried to generate is an OCT virtual clinics. Okay, so trying to save the resources, manage the resources, because they don't necessarily need to see the ophthalmologist. So they get a OCT pictures they can. So if they identify that there is a definitive treating maculopathy or a macular edema as per the ETDRS, then only they get a hospital appointment to see the clinicians. Otherwise, a lot of these, they go back to the screening program for a 6-month screening. Okay. So this is how the treatment program works in the UK. Okay, so the retinopathies, So as I say, there are 2,3s, R3 proliferatives. Okay, they get generally the first line treatment is the lasers. And again, the target from the screening positive R3 to the first treatment is 4 weeks. So we got about another 2 weeks once this referral has come directly to the hospital. So they get lasers. The R2, once you've seen the clinic, you're happy that there's no new vessels. We work closely with the diabetologist. Generally, in my clinic, I've got an endocrinologist, a diabetologist sitting with me as well. So we try to make sure that, you know, it's not only the eyes, it's only one part of the disease. It affects the whole of the body. So to try and see if we can address their metabolic control as well, okay? But obviously, if you've done a full lasers, you do whatever you do, still active, then I tend to go early in these eyes. And if there is any obvious TRD, I tend to go early as well. Similarly, for maculopathy, we have a strict criteria. Generally, all these patients, when they come in, they have dilation OCTs, which is standard. So it's a non-paying kind of a thing. If the central retinal thickness is 400, you were talking about 450, ours is 400 criteria. If it's 400, they get anti-VEGF. Now, the anti-VEGF Lucentis or Eylea, that depends on different hospitals and their local protocols, but in generally, they all get an anti-VEGF. In my hospital, because we give a series of 5 Eylea, that's how the Eylea has been licensed in UK. And again, there's a logistic, you can't see them every month. So what we do is when they're coming for the third sort of a month for the injection, we just have a quick synapsis in the eye and also have a look at the other eye, and then we go, okay? So if there is a responsive, then they go into the PRN, as in when required. Then no response, they could get a steroid or an Ozidec, generally is the first line, or we switch to Iluvien as well. Just a brief line, in the UK, we have started a video trial, which is a vitrectomy versus a standard care, where if patient is not responding after 3 anti-VEGF, the definition of the response is that there's still sort of a macular edema is more than 350. We are now recruiting as a primary vitrectomy plus the ERM and the ILM peel. Okay, even though the previous evidence, I think the logic behind that is that the early vitrectomy may be helping rather than waiting too late before these goes into it. Okay, if the central retinal thickness is less than 400, then depending on the diffuse or the focal, they get treatment. Anti-VEGF, the Avastin is not licensed to be used, just to, okay. So now we'll present some of the data from the Clarity study, which was the in-house UK study done by Shobha Shivaprasad. It was a clinical efficacies of intravitreal aflibercept versus pan-retinal photocoagulations for best-corrected visual acuities at 52. Mind it was a phase 2 non-inferiority study. Okay, this was published in Lancet 2017. Standard inclusion criterias. Okay, but just very briefly, that in these case of patients, they could have been treated previously with PRP because it's a phase 2 feasibility trial. Again, the inclusions are pretty standard. Okay, treatment, they were randomized 1:1 versus anti-VEGF versus lasers. The anti-VEGF was baseline 3 injections, 4, 8, 0, 4, and 8 weeks, and then they were from 12 weeks. If they needed, the disease was active, then they were given. I'll be very quick for the interest of the time. And then they had lasers. They were given lasers in generally 2 shots, and then from 12 weeks onwards, if needed, they were followed 8 weekly rather than the 4 weekly in the aflibercept. Okay, so can I? Yeah, okay. All right. Okay. So this is just the vision criteria. So if you look, the people who were receiving the anti-VEGF, there was about 4 letter gains. Mind it, this is different. When the DRCRN network come, they were proving about 8 letters of improvement. I think we will have another discussion around that later on. And same, okay. So if you look at the complications, pretty standard, but I want to highlight again that people requiring vitrectomies and the new vitreous hemorrhage, though statistically not very significant, what was higher in the PRP group. Okay, so just the last slide. Okay, in the Clarity study, there was only 4.4 injections in 12 months' time, whereas in the DRCRN, there was 7 injections in the DRCRN. Okay, the letter gain was different between the 2 groups as well. But why are we seeing this difference? Probably the Eylea has a long, sort of a different mechanism of actions, has a binding affinities for different molecules, which is VEGF-A, V. I don't need to teach about it, but that's well recognized. And in the Clarity study, there was a mixture of high and low risk diabetic populations, but there was no DMO. And 50% of the people had already had some PRP before they were recruited. So that might explain that they needed less injections, but there was no macular edema, so the visual gain was slightly less as compared to your DRCRN as well. And in DRCRN network, there were high-risk populations, and about 1 in 5 or 20% people had DMO. So in summary, these two landmark trials have given us some insight, some new thoughts to think about how we can manage our PDR cases. But bear in mind, the DRCRN 5-year data has come out, which says that at 5 years, the lasers anti-VEGFs have similar visual acuity effects, but there is a definitive difference in the visual field. Bear in mind, a lot of these people are young people. They're still driving. So this is something gets ignored when we treat people here, okay? The data, but learning from the AMD, yes, there is a reduction in the number of injections as we go on, but there's also a decline in what the vision we gain. But remember, one last line, that anti-VEGF is not therapy, is not a quick fix for all the problems. Thank you.
Thanks, Bhaskar. While Manpreet goes in, you stay there. We can ask you a question. You can have your slides loaded. So I have a question for you. It's very interesting that you said 3 injections of anti-VEGF and primary vitrectomy.
Yeah.
So your criteria for a non-response in a diabetic macular edema case, is it a diabetic macular edema?
These are diabetic macular edema.
So DME cases, or DMO as you say it, you're given 3 injections, that the thickness has not decreased as per criteria more than 50 microns?
Yeah.
Is that what you take?
So no, whatever they started with, okay, they could have 500 or 300.
Yeah.
But we think that after 3 injections gives you, again, bear in mind this is a trial.
Yeah.
Okay, this is not a routine practice.
Right.
Okay, number 2 is, if these people are not responding in 3 injections, it is giving a fair indication that these are probably have a different mechanism of acting in your DMO, right? It's not always the anti-VEGF which is a driving force. They can have an ischemia, they could have some ERMs.
So we know that ERM is there, we know ERM.
Yeah.
So that OCT will tell us. I'm asking you a very simple question. 3 injections, you go ahead and do a primary vitrectomy. Is that what the message is?
Yeah, we're doing a primary vitrectomy with pill,
So whether they have ERM or no ERM, that's a separate matter.
Doesn't
so
matter.
you would also do it in non-ERM cases, non-responding diabetic macular edema.
Yeah.
Dinesh,
no, but are we keeping the visual acuity in mind? I mean, this is regardless of the visual acuity.
No.
So patient has
6.9 up to 6.9. 6.9 is.
So, isn't that overkill?
Well, it can be, but we don't know the data yet. Again, it's a feasibility trial. Okay, so we will need a bigger trial for this as well. So so far there has been very limited role known for vitrectomies in DMEs. Previously, people have done when they have exhausted all the resources. Okay, maybe that's too late.
So what's the basis for operating a patient with 6.9 vision after 3 injections?
It's a patient choice. I mean, they get fed up with the injections as well. So there's a number of injections. The costing, if you look at it, you end up giving 12 injections in a year. Your vitrectomy is 1/5 the cost of that.
So why not give an Ozurdex?
Sorry? Again, the Ozurdex, the efficacy is about, if you look at the data which is coming out, is about 5 injections in 3 years. So again,
Manpreet, are you ready?
So again, costing-wise, vitrectomy works better.
So what does the initial results show, vitrectomy for DME?
We're just still recruiting. We've just started about sort of a 4 months ago.
This is very exciting for all those people who wish to operate. Here is a method. You have somebody saying that you can operate, so nobody is going to take you to court and say, no, I did something wrong.
No, it's voluntary. It's a research trial.
Right.
So all the patients, you get all the information.
Thank you, Bhaskar. Please come and join us here. I'll ask Manpreet to talk on imaging in diabetic macular edema and proliferative diabetic retinopathy. Manpreet is a consultant at Grewala Institute. Manpreet, please.
Thank you, sir. Very good afternoon to all of you. I'll take you through these very basic diagnostic modalities that are commonly used in diabetic retinopathy, and I'll try to stick myself to the time. I'll kickstart with fundus fluorescein angiography. It's basically detection of your retinal vessels and leakage once you inject a fluorescein dye into your peripheral vein. So what happens, so this flow diagram depicts how the dye will reach your eye. So once it is injected into the vein, it comes into your circulatory system, will reach internal carotid, and then subsequently your retinal choroidal vessels. In case of a diabetic, was just a quick video to show. In a diabetic, it's the arteriovenous phase of the angiogram, which will usually depict this retinovascular abnormalities, as it is clearly seen on the video which is playing up at your background. You can very, very clearly appreciate the microaneurysms, the non-perfusion areas, and the neovascularization which is developing in the AV phase of your angiogram. So the next question is, what is the role of FFA in diabetic retinopathy? So this is the table that we'll be basically discussing. I'll better explain it once we start these clinical situations. So first of all, in case of mild to moderate NPDRs, there's usually no need of an angiogram unless there is an associated diabetic macular edema. So FFA in mild moderate NPDR is usually not indicated. In case of severe NPDRs, at times it helps you to differentiate it from your early PDRs. For example, look over the picture and on your right, you can see this early frame of FFA depicts these microvascular abnormality, which is an irma in the nasal retina, and which clearly does not leak in the late phase, and thus it rules out any presence of an NVE. In PDR cases, the image on your right, patient has blocked fluorescence and an NVE seen in the superior-nasal quadrant. This classifies it as a high-risk PDR, and it needs an urgent attention, whereas the picture on the other side is of a low-risk PDR, where you can still wait before you, you can't really wait, but there's no urgency to start it on the day one itself. In case of mild vitreous hemorrhages, again, FFA helps you to confirm the source of bleed. The fundus picture depicts mild vitreous bleed over here. FFA early and late frames picks up the leaky NVD, and this confirms that you are dealing with a case of a PDR. However, when it comes to dense vitreous hemorrhages, FFA is not that important, as it will not pick up any significant information, and so you have to rather rely on your ultrasounds. Next is, does it have any role after treatment? Probably yes. It helps you to confirm successful regression of your NVEs after the PRP. This image is taken 3 months post-laser, and no new NVEs were detected, so you were successful in regressing the disease. So is there any need to augment PRP or not? Like this gentleman, he was type 1 diabetic, treated with PRP for PDR 3 years back. Just came for a regular follow-up, and FFA confirms the presence of NVE inferotemporally, and then the PRP was successfully augmented. Coming to the role of FFA in diabetic macular edema, so look at these 3 examples. If you look at the OCTs, all you see is intraretinal edema, but if you run your angiogram, probably it will add more meaning. For example, this is situation 1. You can see these focal leaks from the microaneurysms in the which is inferior temporal to your fovea. So all you need to do is a good focal, and remember not to treat the microaneurysms which are within the 500 microns of the center of your fovea. This is situation 2. Again, a diabetic treated previously with macular laser. DME was identified on the OCT scan, but once you run your angiography, what you realize is that there is an altogether new area of leaking microaneurysms, and that is what is causing the DME now. This is situation 3, diabetic with gross DME. Until you run your angiography, you won't realize here that you are dealing with an ischemic maculopathy, and whether an anti-VEGF has any role or not, that is still questionable. So to summarize, FFA is important at baseline to identify the type of DME, and it helps you to plan your treatment. Moving on to ultra-wide fields, the basic difference is that a standard mosaic on FFA will give you around 75 degrees, but if you perform your ultra-wide field, you can capture around 200 degrees of your field. Thus, it helps you to identify some peripheral NVEs which could have been missed by the standard traditional 7-field FFA. This is all we are familiar with. This is a normal OCT scan showing the normal retinal morphology. It's a non-invasive test, so has a lot of role when it comes to DR. This probably most of all of us should know by now that OCT is classified into morphological and tractional components. In clinical practice, these are the common patterns that we usually see. This is a diffuse DME, just thickening in the outer nuclear layer. This is a cystic type, and then the serous type where you see the neurosensory detachment. Then there is a tractional component to it. Also, another way of looking at it, and in randomized trials, is center involving and the non-center involving. And then how does the OCT helps you in the management of your DR patients? Like this is a non-center DME over here. You can see there is thickening which is threatening the fovea. So patient just underwent a simple macular laser, and post-laser OCT, there's reduction in the thickness, and your fovea is still well spared. These are just simple DMEs which can be picked up in a very early stages once you have your OCTs with you. Okay, this is a type 2 DR when late phase of your angiogram shows the cystoid edema and few leaky NVEs, but as soon as you run your OCT, you figure out that it is more than just DME, and this anti-VEGF will not be your choice, rather you have to take him up for a vitrectomy. This is the scan pre-vitrectomy and post-vitrectomy. Now, OCT is basically used these days to monitor your treatment response, that is the pre and post of anti-VEGF reduction in retinal fluid, which some people like to look morphologically and some want to look through the automated values. Coming to the last part, which is OCT angiography, this is the latest toy that all of us probably have by now. It is a non-invasive way of looking at your retinal vasculature. OCT images are viewed in tandem with the corresponding structural NFAS and your OCT-B scans. The OCT-A, the basic ability is that it can visualize your each vascular plexus separately. The middle picture, this is at a choriocapillary level depicting your PRP scars, and this is of a superficial plexus. Conventional OCTs, they only capture 3 mm and 6 mm, so it is helpful for you to look at the macular details and the details of your fovea. Again, there are some quantitative parameters available on the OCTA machines that will help you to kind of automate the value of the foveal size, the level of perfusion. On OCTA, it is usually difficult to identify microaneurysms which are masked by your hard exudates, and that very few situations where FFA still carries some role. This image on your left is a case of PDR, so conventional OCT frames will not pick up any further details, but now we have these wide field OCT montages which has added this new perspective. You can see a NVE very clearly in the infero-nasal part of your angiogram. Again, 12 by 12 mm montage, ability to pick up these peripheral NVEs equivalent to what is picked up by the fluorescein angiograms. CSME is difficult unless you combine it with your NFAS and your OCT. Here again, NVD is depicted very beautifully. Again, the major advantage is that repeated follow-up examinations can be easily performed. The color fundus image shows a florid NVD, which is seen on an OCTA image as well. And post-laser, OCTA did not pick up any NVD again, so this is repeatable follow-up exams are easily possible because of these non-invasive investigative modalities. Another example, drastic reduction in the caliber of NVE with pruned edges following an anti-VEGF injection. Now this is something which the world is looking at, that is how to classify the different stages of diabetic retinopathy using OCTA montages. And the future is bright probably for the next AIOS meetings, and thank you very much. Thank you.
Thank you. Manpreet, just stay there. I'll request Professor Atul to start his talk on anti-VEGFs. And so while your thing is loaded, we can ask other questions, sir. So, Manpreet, you have been doing OCTA with fluorescein angiography. Would you say that fluorescein angiography is no longer required and you can go ahead and treat your patients purely on OCTA and OCT?
So, when it comes to diabetic macular edema, fluorescein still has a role.
No, a patient walks into your clinic for the first time who has diabetic retinopathy. You don't know it's DME with PDR.
Yeah,
or
I mean,
no
DME,
PDR
I can, I mean, if it's DME, I will still rely on performing a fluorescein angiography.
So you will never do an angiogram?
Not for DME yet.
The patient has walked in fresh. That we want to give her take home.
Exactly. So once you give him a slit lamp examination, you can make out whether he has a DME component, as in CSME or not. And if we are thinking that it's a CSME that needs to be treated, we are still performing fluorescein angiograms only rather than an OCT.
So you'll do an angiogram for the first visit? And
yes.
Subsequently follow up as per what the angiogram reveals.
Yeah, probably. Yeah. Follow-ups.
The reason we are asking questions to her is because she has to go and present a paper, so she will be leaving us and join us a little later again.
I've just got one comment here. The OCT is an evolving technology. We still don't know. There are a lot of artifacts into it as well. So we need to be very careful when we define ischemia, because a lot of this could be a fluid as well. So I think we are learning, we're getting better, the softwares are getting better, but it is not at this stage where we can replace OCTA from a fluorescein angiogram. There will be a situation where you will need that.
So what about your comments? What do you feel?
I think strongly that fluorescein is there to stay for some time at least, and OCTA has limited right now value, so edema and all that stuff you have to see with fluorescein. And you'll have a pan OCTA, like stitch up the images like the Zeiss is doing. And that also interpretation will be difficult. There are a lot of artifacts also with OCTA. So till such time, fluorescein would be staying, and wide field also.
Thank you, sir. Thank you, Manpreet. Another just a comment, so you can we can start. Another comment is the dark areas on OCTA are areas where there is no flow or low flow, or it can also be a high flow which an Octa doesn't pick up. So an Octa image goes to a place, and once the RBC moves ahead, before it can come, if the flow is so rapid, we will get a no flow area which actually may be a high flow area. So that is where the artifacts are coming in.
Thank you, Ajay, and for inviting me to be part of your course, and to the AIOS members, good afternoon. So we've already been, I think, told by now that we know there are two types of macular edema: the center involving, which requires anti-VEGFs; the non-center involving, which classically does not require anti-VEGF, and one does not prescribe anti-VEGFs for them. You either give good control, you can do a gentle laser, or as Ajay is doing, sub-threshold laser can also be done. So it's basically the center involving edema which troubles us a lot because the vision drops. And there are various definitions. We usually take it over 300. If the edema is crossing into about the 300s, or even to 275 for that matter, 250 is considered normal micrometers in the central 1 millimeter zone. So the role of anti-VEGF is very paramount. Okay. So this is the central involving edema on the left, and this is the non-central involving edema. You can see the cystic space is a little outside. The foveal dip is maintained. And also look at the outer bands, and you see the nearly present, there's a small serous detachment over there. So these kind of patients require anti-VEGF therapy. So the role of anti-VEGF is, because of the VEGF upregulation, you got to counter it. There's a breakdown of the blood-retinal barrier. It's a preferred mode for first-line management for center involving DME. Prevents visual loss, improves vision, in fact, unlike laser. And the choices are with you. Of course, new ones are coming up, for which I'll just tell you a little bit in the last slide. So anti-VEGFs, we've got a lot of questions to ask ourselves, that when to initiate, which treatment to use, which anti-VEGF to use, what regimen, the monthly PRN or treat or extend, efficacy, cost effectiveness. So this resolve, the three studies which I'm going to tell you, the RISE, RIDE and the resolve study, they were basically studies which checked the 15-letter visual acuity gain. So the percentage visual acuity gain, you can see beautifully, has been given the phase 3 randomized controlled trials of RISE, RIDE and resolve. All three showed the sham had lesser visual gain of 15 letters, the ranibizumab had the maximum visual gain, and the ranibizumab 0.3 and 0.5 had a little, nearly the same or even less. So what it said was 0.3 ranibizumab was safe, and safety trial was of course done before. This is the efficacy trial. So efficacy usually the phase 3. Safety is usually phase 1 and phase 2. Any trial you conduct, you first have to do the safety, get the safety approved by the ethical committee, and then you go on to the efficacy trial. Till such time the ethical committee doesn't clear it, you cannot go on to the efficacy trial. So this holds true for all randomized controlled trials or all studies which we've done. Even at AIMS, we find that we have to go through a very rigid ethics committee who have meetings after meetings for that. So anyway, they went through it, and they found that this was the most effective. So they said that ranibizumab, one of the drugs anti-VEGF recommended for DME, in this slide tells you that ranibizumab was very effective, 0.3 milligrams. For laser treatment also, they found the READ and the RESTORE showed that the focal grid visual acuity 15-letter gain was 9% versus 32 and 22.6. So even versus laser, versus sham versus laser was much better. So therefore it is recommended that as compared to laser, as compared to sham, you got to give anti-VEGF first. That was the first slide which showed you that some conclusions we derived. This is a OCT and a Octa of the same patient. It shows the void. These are the void spaces. These are the fluid void spaces, and these spaces are actually the ones which have the edema. And once the edema goes down due to 3, we've given 3 monthly injections. We usually give a loading dose of 3 to 5 for diabetic retinopathy, diabetic macular edema, unlike the AMD where you give 3. So then the edema goes away. So more of a OCT, we follow up on basis on OCT. Initial maybe a fluorescein is required, but for follow-up injections, you just need an OCT and the OCTA if required. So this is the second slide which will tell you a point towards what you should give. So this second slide is a protocol I. This drcr.net is a diabetic retinopathy clinical research network of about 50 hospitals all within the US. They have a network of patients which they get together, and then they see the outcomes. And the outcomes were greater than 15 letters again at 2 years. Sham plus laser or just laser, that means had 18 letter visual gain, and ranibizumab with prompt laser within 1 week, that is combination therapy, 29, and 28 for a deferred laser. And this was 2-year study, 2-year conclusions. And the fourth was using steroid with laser, was 22. So what they concluded in rough was that the ranibizumab with laser, whether deferred or prompt, did very well, and they extended the study from 2 to 5. And the protocol I 5-year study shows that maximum visual gain in the ranibizumab deferred laser group. That may see that what they tell us is, from the point of view of these questions which we are asking ourselves, is that the ranibizumab was effective and laser could be given later at a deferred period. This was the second. Bevacizumab also is very effective. It's an off-label drug, but still one of the trials was done by the drcr.net, the protocol H. They found it a greater reduction in central subfoveal thickness, and at 3 weeks, and no difference between 1 and 2.5. So that was very good that the 2.5 was not recommended, because this drug can cause stroke. I told you it's a large molecule. In the morning also, this is a very large molecule. This stays in 20 minutes. 20 days is a half-life in the bloodstream. So though it's an economical drug, can be easily used. The patient has to be, if he's got a cardiac or a recent stent put, or at least that's what I do. If the recent stroke or a recent CAPBG or a recent stroke, I send him off to the neurology people in the CN center of AIMS. I just tell him to disappear, get all the clearances and come back. Once he comes with the clearances, then I'll give the anti-VEGF. I don't want to play with the fire. It's better to get a clearance of the recent onset. It's an old MI, maybe 5-7 years back, and he's well controlled. There's no need to stop anticoagulants also, we can give it. But for surgery, we do stop clopidogrel, we don't stop ecosprin. That's different. So BOLT was a bevacizumab, another group study which showed that was more effective. So aflibercept is a third drug which has been studied, the Da Vinci and the Vista Vivid. So the Vista Vivid showed, I'll just come straight to the most important studies of the aflibercept group for DME. This showed that 4 weeks or 8 weeks, the dose was the effect was the same versus laser, and they showed that the sustained anatomical functional acuity with aflibercept was more versus laser, and efficacy was similar. That was the most important thing. Is the 2Q4, that is, you give every 4 weeks, or whether you gave it at every 8 weeks. This is 2 milligrams of of aflibercept at 4 weeks, 2 milligrams aflibercept at 8 weeks. The effect was similar. So they said you can even give it at 2 bi-monthly dose. So sometimes I find it's useful to give it very severe edema even monthly. So it's no hard and fast rule that you have to give it at 2. Sometimes at 1, sometimes even later, but generally it's 1 to 2. So this is a little potent. It's got a very strong binding anti-VEGF binding capacity, 140 times more than ranibizumab, but that doesn't make it 140 times more effective. So this is the third very important study which will tell us about the 3 drugs which are right now being used all over the world. The aflibercept 2 milligrams, the ranibizumab 0.3 milligrams, and the bevacizumab 1.2 milligrams. Now look at the 1-year mean change of ETDRS letters. 13.3 mean, 11.2, 9.7. Okay, is this the best? No. If vision is better than 618, if his vision is 6 to 618 and he's got DME, then there's no difference between the 3. If the vision goes below 618, then they say ranibizumab goes very much behind, but between the 2 superior drugs, that's what they say. The study says the aflibercept was slightly superior. Actually, if you see the letter acuity, there's hardly any difference. Ranibizumab has done extremely well with even 0.3 milligrams. So it's not that ranibizumab is not as good as aflibercept. So this is the conclusion from protocol T. So these tells you about the various anti-VEGFs. This is a very interesting. From protocol T, a post hoc analysis was done, and this was done at 5 years. They found they wanted to show that whether early response, a good response at 6 months, was it predictive of long-term destiny. A less than ideal response at 12 weeks, 3 months, did not impede substantial visual gain at 2 years. That means a less than poor patients who did not respond so well to anti-VEGF in protocol T with any of the anti-VEGFs does not mean they are they are basically condemned to have poor visual acuity afterwards. In fact, a large number of eyes, for a large number of eyes. Also, the majority of eyes with less than 3-letter visual gain at 3 months had a final 5-year visual acuity, a very good final visual acuity at 2 years. So what they wanted to say is that initial visual acuity, letter acuity also does not play a role. So you have to keep on treating, and you will probably end up with very good visual acuity. So come to the regimen, you have a fixed treatment regimen, you have a as and when required treat and extend by 2 weeks. So retain and the restore tried the treat and extend, which was inferior, they found it inferior. The drcr.net, which is the most important trial going, which is using the PRN dosing. So persistent DME, you can switch anti-VEGFs combination, you can give rescue laser, or you can give surgery. Rescue laser means you can do it targeted or grid or focal. This is a patient who's got got PDR, and he's uncontrolled, he's got a chronic kidney disease. Such cases we don't inject fluorescein, we just get the Octa done. So these are the kind of cases you can give the anti-VEGF, but post multiple anti-VEGFs he's not responded. So this is the advantage of imaging, that even if the patient has not responded, you might like to switch the antibiotic or go straight to steroids or that kind of therapy. I'm just ending. This is the protocol S, the 3 important protocols which will tell you about which drug to put. The IT, I've told you, the S is for the PDR. Here they found ranibizumab was superior at 4 weekly given versus prompt PRP, and ranibizumab at every 4 weeks. Ranibizumab was found to be non-inferior and a reasonably good alternative. The superior visual acuity, lesser field loss, lesser vitrectomies. But the patient has to come back for follow-up. Lower incidence of DME with ranibizumab. PRP was given whenever there was a failure of anti-VEGF therapy. So what they said was in PDR eyes also anti-VEGF works. So these are the kind of eyes where you have PDR also. You can give the first shot or give 3 shots of anti-VEGF, and then you need lesser burns, targeted laser, and much better. So this is what I would think that if you have PDR eyes, like this patient is similar, the fundus and the FA, and you can see after 3 doses of anti-VEGF, but you also modify the protocol S to adding this laser to it, and then you find when the neovascularization suppresses down, then you can probably get a better result with the laser which you give, and much less laser. But on the contrary, a recent patient who had PDR, a little bit of traction, by mistake, I think I gave an anti-VEGF, and his PDR suddenly increased, and he went into a kind of a TRD involving the macula. So I've just operated him before coming. So it's not that if the traction is there, if the macula is getting threatened, then don't give the anti-VEGF in PDR. So I think PDR has lots of loopholes. It has to be patients who are not having traction, not involving the macula or threatening the macula. It should be patients who are ready to come back for follow-up. And you have to add laser. You can't just say, I keep on injecting ranibizumab or any anti-VEGF for PDR patients. So newer advances, this is the last and the most important slide in the last 5 seconds, 10 seconds I'll tell you. Brolucizumab is a single arm antibody. It's undergone phase 3 trials. It's found to be superior to aflibercept. The Hawk and the Harrier trial I'd like you to read. It's got very encouraging results. They're going superior to it. And the ABC power is a very, it's a DARPin, it's like a protein, antibody protein, and this binds, it's a very potent VEGF binding. So ABC power is also going to come. This is Allergan, and this is Novartis, the same people who got the ranibizumab. So the third most exciting revolution which is coming is the angiopoietin Tie2 pathway. This is the pathway which controls inflammation in the retina. And this pathway controls inflammation elsewhere also. Disruption of this Tie2 pathway causes inflammation, and then you have to give anti-VEGF, VEGF releases there. So there is going to be a revolution that how to affect this pathway by various drugs. So these are 3 things which are very important: the brolucizumab, the ABC power, and the angiopoietin Tie2 pathway. Thank you so much.
Thanks a lot, sir. We can have discussions at the end.
Yeah.
So I'll invite Dr. Dinesh Talwar, who will be talking to us on steroids and DME and PDR, and will be briefly covering up on lasers. If anybody has any questions and you want to ask us now, till Dinesh takes up, you're most welcome. So your last 2 slides were very, very interesting, where you talked about the hybrid approach. I think that's what practically most of us are doing, where we are treating our patients with anti-VEGFs and doing laser much earlier than what has been recommended as a deferred laser thing. So how early after injecting would you laser these patients?
I'll probably give them after about 10 to 15 days when the anti-VEGF effect is max. So I would like to wait 6 months.
So that means you're given the first injection, and after the first injection, it's
If,
not
the,
that
if there's associated edema, that makes a difference. If there's associated edema, I'll wait for the edema to go.
right. So
And
you
I'll
will-
make sure there's no traction involving the close to the macula.
So your laser will be again OCT guided. In case the edema has gone down
Yes.
after the anti-VEGF, then you'll go ahead and do PRP for
PRP.
the PDR.
I give only selected areas I'll put the laser.
All right.
No, our grid is outdated now. We don't like to grid. Focal maximum or sub-threshold. But we don't like to do
So I'll
grid
ask Vishal.
any longer because it's too many laser spots around the macula. It can cause more foveal damage, laser-induced foveal edema, and some submacular scarring. So it can be laser can be more destructive. So not too close, too many spots. The grid involves literally 2 or 3 rows all around like a horseshoe.
So while Dinesh is getting his things ready, we'll request Dr. Vishal Agarwal, who is Associate Professor of Ophthalmology at SMS Medical College, and he has beautiful videos on vitrectomy in both DME and PDR, and he'll tell us how he goes about managing these cases. And I think Vishal's work has increased after what we heard from Dr. Bhaskar, that you start doing vitrectomy after 3 anti-VEGF injections.
Thank you, Dr. Ajay, for having me in this course, and I'll be discussing vitrectomy in diabetic macular edema and PDR cases. So I'll just straight come to the point. Vision-threatening diabetic retinopathy, constitutes 1/3 of all diabetic retinopathy patients. And initial stages like neovascularization and ischemia and edema can be controlled by anti-VEGF agents. But since decades, PPV has been used to treat complications of diabetic retinopathy since the ages of Macamber in 1970s. We have come a long way because of the advent of new wide-angle systems, finer gauges, and high cutter rates, and more advanced technology. So the problem. So these are the current indications in literature: media opacity, non-clearing vitreous hemorrhage, whether it's subhyaloid, whether it's vitreous hemorrhage, traction involving or threatening the macula, traction in the form of VMT, ARM, combined detachments, and of course neovascularization and persistent neovascularization and anterior hyaloid proliferation. When is the problem? So that's a very subjective debate when you intervene in diabetic vitrectomies, but the general consensus is that the threshold of vitrectomy has been going down amongst all surgeons. So the duration of hemorrhage, whether the view is clear. If the view is clear, we'll all prefer to do a little bit of laser and then go inside. Preoperative anti-VEGF, we prefer to do it 1 to 3 days before the surgery. Stopping anticoagulants, still there is a debate about it. The latest article in Graphes by David Wong says that there is no need to stop anticoagulants and just give an anti-VEGF before the surgery for diabetic vitrectomies. Dialysis schedule of the patient, and of course the status of the other eye. If the patient is monocular, you of course want to intervene early. How much? So I'll show you a few videos about how much the surgery has to be done as per my experience. So this is a diabetic ERM and a VMT. So you use multiple stains because there's a lot of vitreochiasis in these cases, and there's a cortical vitreous layer which can be seen by staining with tricot even after induction of the PVD, seemingly induction of the PVD. So you inject tricot, you remove this thin layer along which a little of ERM also is removed, and you have to be gentle, and these are tenacious membranes and they can create a macular hole also if there's a lot of VMT. After that you stain the macula with the trypan blue and you remove the ERM remnants before going with the brilliant blue dye to remove the thin ILM. So the hypothesis says that it increases the oxygenation, and it helps you improve the apart from the contour of the macula, it improves the vision also in around 30 to 40 patients. I do a lot of phaco-vitrectomies these days because more than 50 years of age is the most common age group, and these patients eventually develop cataract. So placing IOL it's very beneficial. It gives you a clear view, and the membrane dissection is absolutely seamless. The only thing you have to remember is that the surgery should be done. If you're not doing it, it should be done by expert surgeon because it should not mess up with the second surgery. It should be quick, it should be clean, and the pupil should be well dilated, the IOL should be well centered. As you can see, the dissection can be performed beautifully under the IOL, which would not have been possible if the lens would have been cataractous. This is another reason why we do that IOL surgery, because there's a lot of the retrolenticular blood which cannot be accessed in a phakic eye. So there's a lot of retrolenticular blood which we can clear easily when the IOL is in place. And the other advantage is that it separates the anterior and the posterior portion. So when we go inside, the surgery becomes much more easy than the phakic eye. So previously, nasal traction in the lateral vitreous bleed we would have observed and we would have lasered more. But these days we go inside because the recurrent bleeds are because of this proliferation. We remove the nasal traction. We have to be a little gentle. Like in this case, it was a little rough pull and there was a break created nasally. But then we realized it early. We did not extend that break. We went with tricot, strained the vitreous, and dissected all around the fibrovascular proliferation. There was a small break nasally, and we lasered it, and the patient did well. And only a small amount of gas sufficed as a tamponade. So this is a dense vitreous bleed. The dictum is to truncate the cone and create a hole in the hyaloid. So all the subhyaloid bleed comes out. So you can have a better view of the anatomy of the various attachments of the proliferation. So there's no point in going inside the posterior pole towards the posterior pole. First go in the periphery, clear it up. So there was a fibrovascular proliferation of the disc. After ILM peeling, we had to remove it. So we did an outside-inside technique, and there was a cleavage plane nasal to the disc. And going with that, we went towards the disc, and it came off in toto. So leaving that would have again caused recurrent bleeds, even though there was no traction on the macula. So doing excess cautery is not recommended, especially if the proliferations are near arcades. So PFCL can act as a good temporary tamponade to control intraoperative bleeding. You just have to put a bubble and just roll it where you are doing the trimming. So it acts as a good hemostasis agent. In this case, there were numerous small bleeders around the arcade. So again, cautery was not used, and a small amount of tricot after the dissection was injected, and it also acts, as a coagulum to the a few bleeders, and it can be done. Here we, opened a real nasty bleeder during the surgery, like this. So in this case, nothing worked. So we just, increased the bottle height, and you cannot cautery near the disc. And we just closed the plugs, waited a few minutes, around 5 minutes, we went inside. So it creates a clot. It's like a tenacious membrane. And then we dissected it, and and the end result looks pretty good. Combined detachments are tough cases. Of course, you have to release the traction. The chandelier light and biomanual surgery are the preferred methods. And you have to remove all the traction around the nasal hole, like in this case. This had a massive submacular hemorrhage also. So we instilled PFCL. And the submacular blood, got rolled out through the nasal break. And the rest of the surgeries, like any rheumatogenic RD, we, remove all the peripheral traction. We have to be very aggressive in these cases, intervene early. Otherwise, these patients become inoperable very early, very soon. So, and a silicone oil tamponade is used. This is NVI, and we just had to drain the hyphema in this case, inject intracameral bevacizumab, and fortunately for us, the posterior pole was good, and the patient had mild vitreous hemorrhage. And this was because of the NVA and the NVI. The patient did fine in the post-op period. So to summarize the previous slide, media opacities, traction involving the macula, at the macula, combined detachments, NVI, and anterior hyaloid proliferation are the current indications for surgery. How much is a very subjective debate. So for me, any patient with dense vitreous hemorrhage, a treatment-naive patient with or without traction on the B scan, I'll intervene within 2 weeks. If the patient has been lasered and there is no traction on the B scan, I might wait for 1 month, but that is the end limit. So indications and the extent keep on evolving with time, and we should all keep in mind that no diabetic vitrectomy is a straightforward procedure. And of course, for the young surgeon, they should be realistic about the capabilities initially and do not take up challenging cases like combined RDs. Of course, despite the best anatomical post-operative outcomes, the vision gain might be modest because of the compromised disc perfusion and the compromised macula. Thank you.
Thanks, Vishal. I'll ask now Dinesh Dr. Dinesh Talwar to give his talk on steroids in DME and PDR. Vishal, I have a small little question for you. Yeah. So when you said how much, come Dinesh. Yeah. So how much would you do in a routine cases where you have a vitreous hemorrhage? Would you go ahead and do a vitreous-based dissection?
So if the eye is phakic, I would not do it. If the eye is pseudo-phakic, I would still do it.
So
but
you will clear it as much as
possible with
without
indentation.
going to the periphery. And if there's no anterior hilar proliferation, if there's an anterior hilar proliferation, obviously
Of course, we have to go there. Yeah.
Yeah.
But in routine courses also.
What do you feel, sir?
Actually, in phakic eyes, the advantage is if you put in air first, then you can go right till the periphery.
Right.
Under air vitrectomy works very well.
Interface.
You because the anterior face of the bubble keeps the lens up.
Right.
The minute you try to touch the lens, you'll see a kind of a fold coming up. So you quickly move the cutter away. So you can go right till the periphery under air.
Now
So I do a lot of under air vitrectomy.
I've also found that where Vishal, you had this nasty bleed, where you waited, that sometimes the bleed is so much that I had to do a complete fluid air exchange, increase the air pressure so much that which was not possible just with the hydrostatic pressure, and it settled down. And I found that in the end you had left a little blood clot there, not gone ahead and completely removed it. I think
That will
probably
again
that is the
avels
trick.
that bleeder, and that will
Yeah,
again cause
so-
bleeding. So
right,
there's no point in going after that. Yeah.
Yeah, Dinesh, thanks.
Thank you, Ajay. You've gone through most of the aspects of management of diabetes. The question now is about the role of steroids. The basic principles of management of diabetic maculopathy are what you've already gone through. The mainstay of treatment is anti-VEGF agents, and this is used both for initiation as well as for maintenance in patients who are responding to the treatment. However, 20% of patients who are on anti-VEGF treatment will not respond. They will require monthly treatment for even 2 years. This is the RESTORE study. And now what do you do? Would you go on and on and on? Well, actually, this is where the issue comes of role of steroids. In patients who are non-responders, intravitreal steroids or steroid implants are definitely indicated. Now, how do you define that? Those are the patients who have an inadequate response, and that is defined by you've given 2 monthly injections consecutively. That means now you have 3 OCTs and there's no change in that, or you have patients who are having multiple recurrences without reaching an endpoint. Those are the patients where steroids are definitely indicated. Steroids can also be indicated, as Atul was just talking about, those who have a recent MI or a recent stroke. Now these patients in ARMD you don't have a choice, but in DME you definitely have the choice of using steroids in these patients without causing any adverse effect. Before you call a patient as non-resolving diabetic macular edema, please rule out any extenuating circumstances, both systemic and ocular. There could be uncontrolled hypertension, there could be uncontrolled diabetes, there could be nephropathy, patient may be actually going into chronic renal failure. And all these things can exacerbate the macular edema, which you will keep on attributing to the fact that he's not responding. And of course, look for how much is the peripheral ischemia in your patient. So, there are different types of categories of patients who come under this non-resolving diabetic macular edema. One category is those who have an incomplete resolution following treatment with laser or intravitreal drugs. The retinal thickness decreases on OCT but does not normalize the foveal contour, and with multiple injections, as I said before, you see there is no significant change occurring. So for example, you could have a situation like this. There is a little bit of improvement, goes back, but you never really reached a resolution of that edema. These are the one category of patients. The second, now in this category of patients, the reason I asked regarding vision when deciding about vitrectomy was this only. You can have patients looking pretty bad on the OCT and the vision could be very good. The question is there an indication for treating them and treating them again and again? So if the patient's visual acuity say is better than 612 and his near vision is better than or equal to N8, with this picture I would still say let's maintain him. We don't need to intervene unless there's a deterioration. And think about it, it's very easy to tell somebody go and get a vitrectomy done for those cysts which you're seeing with 6/9 vision, but how many people over here would be willing to get a vitrectomy done for diabetic macular edema with 6/9 vision? I doubt if even single doctor over here would be willing for that surgery. Neither would I. If, however, the vision is significantly affected, say less than equal to 618, definitely consider a steroid implant in these patients. The other category of patients are whom have no resolution following your treatment, and this is a rare situation. In a study called the Protocol U, when they actually picked up patients who were not responding and then subjected them to treatment with 3 consecutive injections of anti-VEGF, they found 50% of the patients who were refractory suddenly became okay. So most of the times when you say no resolution, you are talking about patients who've not followed up and got proper treatment, rather than those who are really refractory to treatment. But once you've done that, you can give a trial of intravitreal Ozurdex for a sustained effect, followed by use of anti-VEGF agents. I don't like to give Ozurdex more than twice a year as per its initial product prescription, and in the interim period I will use anti-VEGF agents to cover up as required. The most important thing when you're giving these treatments is a 4-weekly follow-up by OCT to pick up an early recurrence. And just to show you that, now you see a patient here, 1 injection, second, another, nothing was happening, and suddenly with 1 Ozurdex, the edema started resolving. So it works like a cannon where the rifle is not working. And this is just to show the Ozurdex. But the second aspect of Ozurdex is, this was a patient who was getting multiple recurrences, got 1 injection of Ozurdex, beautiful improvement, beautiful. And you got a wow factor. And then 6 months later, you have a oh my God factor. So this is the problem with Ozurdex. There are patients who get they get a rebound, and that is why the follow-up is very important. And the moment you see the first scene that the OCT is showing a worsening, you should put the patient on anti-VEGF if 6 months have not gone by, and you can put the patient on Ozurdex if 6 months have gone by. What can you expect from repeated steroid injections or a combination of steroid and anti-VEGF injections? The usual kind of improvement is 5 to 10 letters with improvement of the foveal contour. You really don't get more improvement than what you get with anti-VEGF agents. How can you decide which patient is likely to improve? Now you look carefully. In this patient, you could actually see the ELM, and you could see the ISOS junction was not too bad. And this patient got a better recovery as compared to this, where there was a total loss of the ISOS junction and external limiting membrane. So this is how you can get some idea as is this patient going to respond well or not. The second aspect is about proliferative diabetic retinopathy, and the basic over here, the mainstay of management is still lasers. Here I differentiate PDR into that with flat neovascularization and that with raised neovascularization, and in fact Atul touched on it in a way. If you have flat neovascularization with CSME, give an anti-VEGF agent and complete the PRP quickly. You will not get any tractional effects. If you have raised neovascularization with CSME, this is a situation where you should complete your laser first to take care of the anchoring effect, and then consider doing the management of the macular edema with steroids. The laser effects are destructive and adhesive, and there's also the subthreshold effects, which is actually Ajay's forte, and I'm not going to go into it. If you have, as far as the subthreshold micropulse laser is concerned, it's supposed to help in reproliferation of the RP and helps in resolution of leaks in patients with CSME, so should be good for DME, but we don't have enough studies yet on the topic. As far as the normal thermal lasers are concerned, you have you can use it to treat the retinal breaks as an adhesive modality. You can also use it for localized TRDs actually as an adhesive modality to delimit those. In addition to that, you can use it to stop the leaks in terms of CSME, focal leaks, and finally you can use it to destroy areas of ischemia or those of abnormal tissue, the neovascularization. The groups are basically diabetic maculopathy, non-proliferative diabetic retinopathy, especially the severe and very severe cases who have a 50 to 75% risk of going to PDR within a year. Today, 20 years later on, I will not keep these guys under follow-up. I would prefer to consider treating these patients. Of course, with PDR, there is no question that you would treat. In addition, there are specific groups like one-eyed patients, non-compliant patients, pregnant ladies who already have significant diabetic retinopathy whom you should consider for treatment. The issue basically comes only in those with maculopathy with PDR, which I've just mentioned. If it's surface neovascularization, anti-VEGF plus laser. If it is raised neovascularization, steroids after you finish the laser. I'm just completing 2 more slides. Also in patients with traction RD, if you can get laser into the attached components of the retina, the results of vitrectomy become better, and the vitrectomy per se becomes an easier procedure. In patients who have a rebleed after your initial completion of PRP, go anteriorly right up to the aura, cover any skip areas, and also posteriorly up to this margin. The techniques, the important thing is that when you're doing a focal macular laser, the end point is a darkening of the microaneurysm or a blanching. One of these 2 things should happen for you to say you've achieved what you want to do. For PRP, in order to get your half burn diameter between spots, the distance when you place the burn should be 1 burn diameter. And the chances are, more often than not, I see under treatment rather than over treatment of a PRP, which is probably contributing to the patients not responding. In case your burn is not coming, initially increase the power. If the power doesn't increase the duration. Try to avoid going beyond 0.2 seconds because it becomes painful for the patient. And of course, try to start with the inferior quadrant so that if it bleeds, at least that quadrant has been covered. This is what happens if you do too much in one go, and especially if you use too intense burns. So be careful about the intensity of the burns. We don't want more than grade 3 burns in these patients. And with this treatment, we expect that we would decrease significantly the risk of severe vision loss in our patients. However, I would still say for this country, laser is the mainstay of treatment, with intravitreal anti-VEGFs having an adjunctive role and steroids playing a role in managing the concomitant macular edema. Thank you very much, ladies and gentlemen.
Thanks, Dinesh. Now I'll request Dr. Ritu to give a talk on management of cataract in diabetes. And while Dinesh, you are there, this single question: if you have a raised neovascularization, in that case, would you be a little impatient that you may intervene surgically earlier?
I am very particular about the vision that I'm talking about, that I'm seeing. A patient who's got very good vision, I would not be in a hurry to intervene. I think Vishal has shown you enough cases which look very simple can turn out to be a nightmare when you go and perform them. The first adage of a physician is what I would like to follow: do no harm. And in diabetic vitrectomies, it's very easy to do harm.
Thanks, Dinesh. Dr. Ritu. After this, we'll have maybe 1 or 2 situations. Yeah, please go ahead. Yeah. So we have.
In today's world, I would say if you want to give triamcinolone, don't give 4 milligram. Either give 1 or 2 milligram. You will decrease the risks of glaucoma, but the duration of action of the drug will go down to around 6 to 8 weeks. It doesn't matter. In patients who can't afford Ozurdex, the choice is between 40,000 and 56 rupees for an injection.
2 milligram works well.
Just on that, there was a meta-analysis which says that even if we give an orbital flow triamcinolone, that works equally well. You don't necessarily always have to give intravitreal triamcinolone.
Good afternoon, and it's nice to see a full house. And we've been discussing a lot about diabetes, and along with diabetes, we often do have cataract. In fact, it's 2 to 5 times more frequent in diabetics. And since India is becoming the diabetic capital of the world now, almost 25% of all our cataract patients have diabetes. Now, to optimize the visual outcome, it's a complicated patient who already is compromised, retina is compromised, and we need to have a very good outcome of the cataract surgery. So I'll be giving some pointers towards that. Now, what can be the indications for cataract surgery in our diabetic patients? They could be having an advanced cataract which needs to be removed, or you may be having a poor visualization of the posterior segment, which you need to follow up the patient to see the retina to do a laser, Or as Dr. Vishal pointed out, it could be a part of your VR surgery where you want a better visualization, or patient could have an associated glaucoma which may also need good examination of the optic disc. So what are our main concerns? Our main concerns are post-op cystoid macular edema, a worsening of your diabetic macular edema. These cases can progress to PDR. You can have increased inflammation. They're also more prone to infections. And these are challenging cases which really need experienced hands. We need to take care of the comorbidities, which could be preoperatively, intraoperative, and post-op, and I'll be talking about this. So the systemic comorbidities, as was pointed out by the previous speaker, it's very important to get a good metabolic control. Whether the patient has nephropathy, is the patient on dialysis, you need to avoid certain nephrotoxic drugs. If the patient has associated cardiac problems, we may need to stop the anticoagulants. So nowadays we do not stop ecosprin. And again, if the patient has any diabetic foot, whether it's infected, so all this needs to be managed preoperatively. A good metabolic control, also from legal point of view, it's important to know that the blood sugars are well controlled, and a PP less than 180 mg is important. A good control of their blood pressure, and of course their lipid profile and proteinuria. These are other things that we need to look into. And here is just a case to show that a patient who had cataract, and you can see in the slides above, he has moderate to severe NPDR, but he was first controlled systemically, and once the retina improved, the picture improved, only then the patient was taken up for cataract surgery. So pre-op, we want to look at the HbA1c and we want to reduce it, and it's been shown that a 1% reduction in the HbA1c helps to reduce the risk for the other complications, and especially for cataract also, it's shown that the patients do not advance to cataract surgery. But a very drastic reduction is not advisable, and we should be in close touch with the endocrinologist to advise them that a slow reduction in the HbA1c is required. And if you find a patient who is having a sudden decrease in HbA1c, especially patients who have been put on intensive insulin therapy, they do need to have more frequent fundus examinations. So pre-op, some of the anterior segment comorbidities which we commonly come across are inflammation. And it's well known that diabetic patients have greater inflammatory mediators, and so these patients should be put on NSAIDs, ideally 1 week prior to it, and post-op continue it for 4 to 8 weeks. The ocular surface again warrants attention, and we must stabilize the ocular surface, as these patients again are prone to corneal hypoesthesia. They have associated myobomitis. They may be having delayed epithelial healing, and also an unstable tear film. So this may impact, especially where you're doing a toric lens. All the premium lenses like multifocals are usually a no-no, but in case of a patient who is a well-controlled NPDR and you're considering a multifocal, so do stabilize the ocular surface so that you get the accurate readings for your keratometry. Again, look at the iris carefully. You may be not being able to visualize the fundus, but if you do see NVI, that means the patient is having PDR and needs to be either injected and treated prior to taking up the patient. Associated glaucoma is very common. If the patient is well controlled on a single medication, just cataract surgery alone may suffice, and you can continue the post-op anti-glaucoma medications. But if the patient is already on maximal medical therapy, you would like to plan a glaucoma surgery along with it. Those cases who have just about, say, 2 medications, you need to see, does the patient have good control? Is the patient going to come for follow-ups? Or if the damage is already extensive, then you may want to do a combined surgery. A proper assessment of the posterior segment is already important, and in this forum of already retina specialists, I don't need to dwell on that. But documentation is something we all should be cautious about, and since we are susceptible to legal action, So we must, even as anterior segment surgeons, try to take the fundus photographs, do the OCT and B-scan. So the treatment for the posterior segment should always precede the cataract surgery if the visibility permits. And depending on the clarity of the lens, depending on the stages of the diabetic retinopathy, you can decide what you want to do. If there's no diabetic retinopathy or a mild to moderate NPDR, early surgery would be warranted so that you can continue to follow up your patients and see their fundus examination. If the patient already has maculopathy, it's already been elaborated by the previous speaker, so I will not go into that. And in cases of PDR, you may be planning a combined or a sequential surgery. It's also been seen that following even an uneventful phaco, the central macular thickness does tend to increase. So all the more reason to stabilize the posterior segment prior to taking up the patients for cataract. So intraoperatively, we have a lot of challenges. These patients have poorly dilating pupils. They have an endothelial dysfunction. The zonules are often weak, especially in patients who've been receiving multiple injections. And even the cataract may be a very advanced cataract. So be careful that you have everything that you require in your armamentarium. In the OT, you have the viscoelastics, which are required, like Viscoat. You have the pupillary expanders. You have a CTR available in case the zonules are weak. You may need capsular hooks and the right kind of IOL. The selection of the IOL, mostly we do like to go in for hydrophobic acrylic IOLs. And the biometry is very important, especially in patients who have silicone oil. Make sure that your biometry is correct. Again, as I said, multifocals should be avoided in such patients, and AC IOLs also. So it's been seen that phaco and eyes with diabetic retinopathy or PDR should also be followed up very closely post-operatively, and there is an increased incidence of complications. So it should be done by an expert surgeon. So some of the intraoperative pearls, I would say, prefer to go for a peribulbar block. Rexus should be of an optimum size so that post-op the fundus can be periphery can be viewed well. Use a good viscoelastic to protect the endothelium. And in patients who've undergone a vitrectomy and you find that there's a dense posterior subcapsular cataract, be cautious. They could be having a PC defect, and you may want to avoid hydrodissection in such cases. The zonules may be lax because of multiple injections. Do a thorough cortical cleanup and a capsule polishing, and try to put the IOL in the bag. Remove all post-op viscoelastic to avoid IOP spikes and reaction post-operatively. Post-op management, as far as inflammation goes, continue to use topical steroids and NSAIDs aggressively. Use lubricants, anti-glaucoma medication. An early YAG should be avoided, and a close follow-up with a retina consultant for the posterior segment is very important. So my take-home message is that these patients can be managed very well, but make sure that you stabilize the metabolic control prior to surgery. Look after all the comorbidities. Early surgery is advisable so that you can follow up the retina. And even after cataract surgery, make sure that the retina specialist is closely following up your patients. Thank you.
Thanks, Dr. Ritu, and thank you everybody for being here. I think we were able to make a little difference in your knowledge about diabetic retinopathy. We have paucity of time, and I don't think we can have an interactive session. We have been telling the All India Ophthalmic Society to increase our time for ICs, but unfortunately that is what we get. Thank you all very much. I request all the faculty to be here. We can take a quick photograph before the next course starts. We have 3 minutes.